Hi, I'm Susan Taylor with Scripps Health in San Diego, California. Please subscribe to our Scripps Health YouTube channel. We've got great information for you featuring the latest technology, our stellar doctors, and inspiring patient stories. Okay, take a deep breath. You are pregnant. But with the overwhelming joy comes a lot of anxiety once the doctor tells you that you have a high-risk pregnancy. What is it? How do you deal with it to ensure your health and the health of your baby? Joining us is Dr. Daneshmand, Medical Director of Maternal and Fetal Medicine at Scripps Clinic, and Sarah Fernandez, who is a prenatal genetic counselor. Thanks so much for being with us.
Thank you for having us.
We appreciate it. Let's start off with the basics. What is considered a high-risk pregnancy?
So a high-risk pregnancy is a pregnancy where there are more risk factors that predispose the mom and the baby to complications more than usual. And these may be extremes of age, for example, increased body mass index, pre-existing conditions such as high blood pressure or chronic hypertension, endocrine disorders such as thyroid abnormality. Someone may be low on their thyroid or elevated in their thyroid activity. Diabetes could be type 1 diabetes, type 2 diabetes, or diabetes diagnosed during pregnancy.
That's called, what's that? That's called?
Gestational diabetes.
Gestational diabetes. And what would cause you to have diabetes during pregnancy?
So diabetes could be because of, for example, a patient may be have an increased body mass index. Patient can have, based on genetic risk factors, for example, African American patients from South America may have an increased risk. Extremes of age again, so patients that are usually 35 and older have a high risk of having diabetes. Usually multiple gestations. Patients
Multiple
that have,
gestations, you mean?
twins or triplets.
Oh, okay.
They have an increased risk.
When you talk about extremes of age, I know that women over the age of 35 is considered a high-risk pregnancy. Is it also considered a high-risk pregnancy if you're very young?
Yes, so women that are younger than age of 17 have a high risk for not only fetal abnormalities, a condition called gastroschisis, which is an abdominal wall defect with the baby, but they have a high risk for having preterm labor and delivery, which is a huge condition, a huge issue in this country of ours. 1 out of every 10 babies are born prematurely in the U.S.
Let's go back and talk about gestational diabetes. You get the diabetes during the pregnancy because?
Well, pregnancy is more of an insulin-resistant state. So patients are more, when you get pregnant when you enter into your 3rd trimester in the 24 to 28 week period, we screen patients for gestational diabetes because your body becomes more insulin resistant. So the cells need sugar. And so when the cells become more resistant, sugar is not getting into the cells, so your blood contains more sugar, and that carries complications for both mom and baby.
And what about the Scripps Whittier Diabetes Institute? What kind of special programs do they offer for women who have pre-existing diabetes or who may develop diabetes?
Yeah, this is what's fantastic here, Susan. Scripps Whittier offers diabetes services not only for an outpatient, but also for inpatient services. So any patient who's got issues with diabetes, such as type 1 diabetes, for management, for counseling. They also even have behavioral health. If a patient is struggling with their diabetes and they need help managing that, they're having anxiety about it, for example. They even offer services for that. So Scripps Whittier is incredible because a lot of times there's a gap between managing patients with diabetes between the practitioners and the endocrinologists, and Scripps Whittier just brings that all together.
And then you briefly touched on a history of heart disease or high blood pressure. Why would that be considered a risk factor?
Well, if a patient has hypertension, there are multiple risks, that are associated with both mom and baby. With mom, the mom has an increased risk of developing preeclampsia, which is a condition in pregnancy where blood pressures are elevated. Patients with hypertension can also have conditions such as the baby not growing, something called fetal growth restriction. They could also have their placenta separated from the uterine wall if their pressures are too high, a condition called placental abruption. Moms could also have strokes. They could have myocardial infarctions or heart attacks. Wow. So certainly these are risk factors. Again, when we talk about high-risk pregnancies, when a patient is seen initially, we review the patient's history and their risk factors, and one of the risk factors, if it's hypertension, we manage the patient accordingly based on those risk factors.
If you've had a history of past pregnancy problems, including maybe, you go into labor early, preterm labor, or you have had a miscarriage, does that automatically mean that if you get pregnant again, you're going to have the same problems?
Not necessarily, but you certainly have a higher risk. A patient who's had a history of a preterm delivery, that's the biggest risk factor for having subsequent preterm deliveries. So therefore, that's a risk factor. So if a patient is seen and has had that history, let's say someone went into spontaneous labor at 32 or 33 weeks, that patient is going to be managed differently than someone who went full term.
And then what about having an infectious disease? Let's say you had hepatitis at some point.
Of course. Again, their risk factors depends on if the patient is, for example, a chronic carrier for, let's say, hepatitis B. There are risks associated with passing that down to baby through the placenta, and those patients need, again, counseling regarding the risks and their options.
So given the risk factors that Dr. D has described, is there a genetic component to any of this, Sarah?
There can be a genetic component to developing things like diabetes and high blood pressure. A lot of times the gestational diabetes that develops during pregnancy is more a product of the pregnancy environment, but there's always genetics at play. So someone who has a family history of those conditions may be at a higher risk if they have a lot of the environmental factors that impact the risk as well.
So how do you know you have a high-risk pregnancy before you get pregnant?
So that's when preconception counseling is very important. So we've got phenomenal physicians here in San Diego, especially at Scripps. And so that's, if a patient is planning on getting pregnant, it's imperative that they speak to their healthcare provider, because then they'll review their history, they'll review their family history. Like Sarah mentioned, for example, if a patient has a mom who delivered, she or her sibling, for example, and had preeclampsia, she is at risk for developing preeclampsia, again, elevation in her blood pressure. Reviewing of environmental toxin exposures, like if the patient's smoking or if the patient is on any medications such as anti-epileptic medications, seizure medications that may predispose the fetus to complications, such as structural abnormalities, spina bifida, openings in the baby's spine, heart defects. There are certain medications for depression, for example, that impose an increased risk for the baby. So it's really important, Susan, for patients that are planning on conceiving to speak to their healthcare provider and just to go over everything. That way, at least they can meet with the appropriate people and have as much of a planned pregnancy as possible. Pregnancies are hard to plan. I always tell patients, listen, you got to go with the flow, but at the same time, you want to be informed as much as possible.
So in a couple of minutes, we're going to talk about how you should manage a high-risk pregnancy. Want to get a pen and paper, because there'll be some things that you want to write down, so we'll come back to that in just a couple of minutes. How do you manage a high-risk pregnancy? What kind of tests do you run for patients who have high-risk pregnancies?
So it depends on the condition. I mean, if a patient, for example, has elevated blood pressures, she's a chronic hypertensive, we tend to run some basic labs like your cell blood count. We want to make sure that your platelet counts are, for example, normal. We check your chemistry panel, which includes your sodium, potassium, your renal function, which is serum creatinine. We do a 24-hour urine collection. So mom, she basically pees for 24 hours, and we assess the protein, because patients that develop preeclampsia may have protein that they spill in their urine, which is typically not done in a non-pregnant patient. Ultrasound, so patients get an ultrasound usually with their physician, and then they may come in with us for an ultrasound called the nuchal translucency screen, which is looking behind the baby's neck between the skin and the soft tissue. They also get their anatomy scan between 18 to 20 weeks. If a mom has had a history, if the mom is a diabetic or has had a history of a baby with a congenital heart defect, or she herself has had heart disease or heart defect, then they get a fetal echocardiogram, which is looking at the heart in detail with ultrasound. And depending, again, on the pre-existing condition, again, hypertension, diabetes, autoimmune disorders, they get serial growth scans just to make sure that the baby's growing appropriately, the fluid levels are fine. And then once they reach about 33, 34 weeks, that's when we start more intense monitoring, because that's when babies really start putting on the weight, and we want to make sure babies are doing well.
So you are a perinatologist. Explain to the audience what that is.
A perinatologist is really a consultant to obstetricians, to midwives, to family practitioners. We view us as fetal imaging doctors, so we are radiologists for the baby when mom is pregnant, and also as consultants, as internal medicine physicians for pregnancy. We basically assist our obstetricians, our midwives, family practitioners with any questions they may have. If there are any issues with mom that again predispose them to complications for baby or mom, that's when we get in.
So if I have a high-risk pregnancy, I should still go to my OBGYN first, and then they would refer me to you as a perinatologist? Or if I'm thinking I have a high-risk pregnancy, or I know I do I go see a perinatologist first?
You could, but we've got incredible physicians at Scripps. We really do. Our obstetricians are phenomenal. So, and it's always at Scripps, a very much a team approach. So it's your obstetrician, your family practitioner, your internal medicine, your maternal fetal medicine specialist, the nurses, the midwives, the nutritionists, the genetic counselors, the sonographers. I mean, we all work very closely together and communicate very well with one another.
Sarah, talk about a genetic counselor. What is it that you're actually screening for?
So a genetic counselor specifically is someone that's had advanced training in genetics and a little bit of training in counseling and decision-making techniques. We screen for a few conditions pretty commonly and routinely across the board. Anyone who's pregnant, but particularly women over 35, are offered screening for different chromosome conditions, things like Down syndrome and a condition called trisomy 18.
What is that?
So typically we have 46 chromosomes, and these chromosomes are like the instructions that tell our body how to grow and develop. People with a chromosome condition, like I mentioned, they have 47 rather than 46. Down syndrome is an extra copy of the chromosome pair number 21, and then trisomy 18 is an extra copy of 18.
And can women come in before they become pregnant for genetic counseling?
So another common thing we screen for during pregnancy, but also before pregnancy, is something called carrier screening. Some people can be a carrier of a genetic disease, and that just means that they are healthy themselves, but they have the potential to have a child with that condition.
What would give me some examples of that?
Some things like cystic fibrosis is a genetic lung disease that some people may have heard about before. There's another one frequently recommended that we screen for called spinal muscular atrophy, which is a muscle disease. And those are conditions where both parents would need to be carriers before we would worry about them having a child with the condition. There are other genetic diseases that can run in the family that only one parent needs to be a carrier for before they have a chance to have a child with it.
If one parent is found to be a carrier, is this a reason to not get pregnant? Or if both parents are found to be a carrier, is this a reason to not get pregnant?
It's going to be a very personal decision for each couple.
It's a hard conversation to have.
Absolutely. So people who find that they are at risk to have a child with these genetic conditions because one or both of them are carriers, they do have options that we discuss with them. Some people choose to go through IVF, which is in vitro fertilization, when they take the egg and sperm outside the body, create an embryo in a lab, and we can test some cells from that embryo to see if that embryo would be affected with that genetic condition. Some couples may go through this process and choose to only transfer embryos that are unaffected. It's a very time-consuming, exactly. It's a very time-consuming and unfortunately expensive process, but it is one option. Other people might choose to use a donor, a genetic donor, so someone who we know is not a carrier. And other people might choose adoption or routes like that.
Let's say you find a genetic abnormality. What happens then?
So it gets a bit complex. We do have, all screening in pregnancy can be complex. We do have some tests that are just screening tests. So those can be wrong. And in cases like that, where those come back and say there's a high risk for a genetic disease in pregnancy, we counsel the patients about the likelihood that the test is correct and what steps we can take next to try to find out with more certainty whether it is correct. But in those cases where we do make a genetic diagnosis in pregnancy, with those patients, we talk with them about what the condition will be like, what the outcome would be expected to be, and what their options are. We provide a lot of support resources as well.
And what's an amniocentesis?
That is a test where we, using ultrasound guidance, to monitor the baby. We do insert a needle through the abdomen, or the physicians do this one. They collect some of the fluid that's around the baby, and in that fluid is the baby's skin cells. So they can take those skin cells in the lab and they can culture them, which lets them grow, so we get a large sample of cells. And we can take those cells and we can test for different things we're concerned about. So we can look at the chromosomes to make sure there aren't extra, and we can test for genetic diseases that parents might be carriers for or that might be running in the family.
There's been some controversy, though, about an amniocentesis, right? Some people are really kind of hesitant to have that done. How come?
There's a loss rate associated with it. So patients that have, for example, struggled conceiving for a long time, patients who've gone through IVF, who spent a lot of money, they're always worried about the potential loss rate. The loss rate is very low, but still, it also depends, again, like Sarah mentioned, is a very personal decision. If patients are not going to do anything about the information that they're going to obtain from it, they decline doing an amniocentesis. But it's usually the loss rate associated.
When you say loss rate, you mean that there's
losing the pregnancy, a procedure-related loss.
What's the
About 1 in 800.
Okay.
With doing an amniocentesis.
It's very small. So, how do you manage? We referenced this before. Let's talk about it now. How do you manage a high-risk pregnancy, which is, let's say, complicated by maternal diabetes?
So again, multidisciplinary approach. It's a team effort, including the patient. So we provided at Scripps in a very comprehensive, compassionate, respectful way. We really do. And I think, again, it takes the team. It's preconception counseling. When a patient is a diabetic, initially there are certain labs that are drawn. One of them is called the hemoglobin A1C, which assesses the patient's glycemic control over the past several months. If that is elevated, for example, the patient may be admitted to the hospital for diabetes care, so antepartum management.
Antepartum means?
Means during the pregnancy. So this patient may require medications orally to bring down their blood sugars, or they may require insulin. Some of these patients are pre-existing diabetics, may be on an insulin pump, for example. We manage these patients with the Whittier team, with the endocrinologist and the diabetic educators and the nutritionists. This patient will require frequent ultrasounds throughout the pregnancy, because babies that are exposed to moms with diabetes, for example, type 1 diabetes, could also be growth restricted or could also be very big, and this carries a risk to the pregnancy. These patients are just followed very closely. Like I mentioned earlier, in the 3rd trimester, we do something called a non-stress test, which is listening to the baby's heartbeat twice a week, and that has a very good negative predictive value, which means that when you see accelerations in the baby's heart rate during the monitoring, that tells you the baby's happy. Movements increase.
We want a happy baby. How do you manage high blood pressure?
High blood pressure, again, multidisciplinary approach. We follow these patients very closely. Again, we do some baseline labs. The patients are usually, I ask them to, for example, check their blood pressures routinely themselves. Again, nutritional counseling. It goes back really to the basics, but for us, it's very intensive monitoring, frequent visits to the office. If the patient's blood pressures are elevated, placing them on antihypertensive medications or high blood pressure medications, frequent labs. Patients go through a lot.
Sure. What if you have an autoimmune disorder during pregnancy? Explain what that is, and then how do you manage that?
So autoimmune disorders are disorders that women unfortunately tend to attack their own bodies. So autoimmune disorders such as lupus or systemic lupus erythematosus or rheumatoid arthritis are examples of an autoimmune disorder. Sjogren's disease, for example, is another example. A patient, for example, with lupus depends on which organs are affected. But if a patient, for example, has lupus that affects her kidneys, then that predisposes the patient to an increased risk, again, for preeclampsia or toxemia. In pregnancy, again, elevations in her blood pressure. It puts the baby at an increased risk for growth restriction, increases the risk for premature labor and delivery. So these patients, again, they get baseline labs and, again, are followed very closely with frequent ultrasounds, consultations with the perinatologist, and with their routine visits with their obstetrician.
And let's say you become pregnant with twins or triplets. How do you manage that?
So twins have an increased risk for developing preeclampsia again, developing gestational diabetes, premature birth. So twins on average deliver at around 36 weeks of gestation, but they can deliver earlier. They also have an increased risk for anemia because a lot of iron is used to increase mom's red blood cell mass. So twins, again, a multidisciplinary approach. None of us are. I never take credit for taking care of a patient solely. It's really a team approach. But twins, when they come in, again, the main thing with twins, Susan, during pregnancy is the number of placentations, how many placentas the babies have. So if twins have two placentas, where they're not sharing one placenta.
And the placenta is?
The placenta is really, when we think about pregnancy, we always think about mom, placenta, and baby. And the placenta is really the connection between mom and baby. It's where everything happens. Without a healthy placenta, we don't have healthy pregnancies. So the number of placentations is very important as far as how you manage a patient with multiples. If a patient has one placenta with twins, then that increases the risk for something called twin-to-twin transfusion syndrome, which is one baby giving a lot more blood to the other than is receiving back. And that carries, unfortunately, an increased risk for the pregnancy.
Anything, let's say, how do you manage a high-risk pregnancy if there's some kind of genetic abnormality, Sarah?
So once something is diagnosed and we find out that the baby has a genetic disease, we discuss we have very sensitive conversations with the couple. Not every couple will make the same choice when faced with these sorts of situations, but we strive to create a space where people can talk through their options and feel safe and supported in whatever they decide to do. Some people use this time to decide what they want to do going forward with the pregnancy. Other people use the time to start to build their support networks, learn more about what their life will like going forward, or what their life will look like going forward. And what we try to do is help guide them down the path, help them choose which path is right for their family, and get them started on whichever direction they need to go.
So the bottom line, if you are thinking about getting pregnant, what should you do to prepare?
Best thing is preconception counseling. Meet with your provider, go through your history, your family history. Movements.
We want a happy baby.
We want happy babies, yes.
How do you manage high blood pressure?
Be as informed as possible before you get pregnant, because there are certain things, remember, in the first trimester that you can avoid that can have long-lasting effects on your pregnancy. We talked about environmental toxin exposure, medications, alcohol, smoking, folate, just taking folic acid at least a month prior to conceiving is beneficial for reducing the risk of spina bifida or any openings in the baby's spine. So I think that's probably that's the time when we can have the most amount of impact on our moms and our babies.
And from a genetic standpoint, that carrier screening that I discussed to see if a parent is a carrier for a genetic disease, that can be performed before a pregnancy. It's really the ideal time to find out about these sorts of things. So that's something that people can discuss with their primary care physicians or their obstetricians. If they have very detailed questions about it or a family history of a genetic disease, they can come and see a genetic counselor to discuss it as well.
So the bottom line, if you are thinking about getting pregnant, what should you do to prepare?
Best thing is preconception counseling. Meet with your provider, go through your history, your family history. Be as informed as possible before you get pregnant, because there are certain things, remember, in the first trimester that you can avoid that can have long-lasting effects on your pregnancy. We talked about environmental toxin exposure, medications, alcohol, smoking, folate, just taking folic acid at least a month prior to conceiving is beneficial for reducing the risk of spina bifida or any openings in the baby's spine. So I think that's probably that's the time when we can have the most amount of impact on our moms and our babies.
And from a genetic standpoint, that carrier screening that I discussed to see if a parent is a carrier for a genetic disease, that can be performed before a pregnancy. It's really the ideal time to find out about these sorts of things. So that's something that people can discuss with their primary care physicians or their obstetricians. If they have very detailed questions about it or a family history of a genetic disease, they can come and see a genetic counselor to discuss it as well.
And all of this preparation, would you suggest that, no matter what age you should be prepared like this? Let's say you're 25, 28, 30. Is it the same type of preparation in terms of the knowledge of what's going to happen when you get pregnant versus, let's say, if you're over 35?
Absolutely. I mean, complications happen in any pregnancy at any age. For example, Down syndrome can happen with a mom that's 25 years of age. So I think being informed and being prepared. I mean, Susan, pregnancy is just such a phenomenal experience. But also what a woman does during pregnancy, the environmental influences on that child's DNA is lifelong lasting. So this is epigenetics, where the function of the DNA basically changes depending on the environment that baby's in. So I always tell patients, really, this is such a critical time for a mom to be eating very healthy, to be prepared for her pregnancy, for her to be exercising, for her mind to be calm and cool, right? Depression is something that affects a lot of our wonderful women. So it's just a magical time.
Any final thoughts?
When a woman becomes pregnant, she's going to be offered a lot of different testing options. It can get very overwhelming and confusing. So if needed, the Scripps prenatal genetic counselors are here to act as interpreters for people to get through all of that complex medical data.
Any final thoughts, doctor?
I think I tell patients, again, most important thing is trust in your healthcare providers. We're all here to take care of our patients. We want the best for our patients, and trust and communication are very important to a better outcome for both mom and baby.
And no question is too silly, too unimportant.
Absolutely
Ask
not.
away.
Absolutely not. Yeah, this is a time when, we have to be just very open with one another, and this is why I find this field just so exciting, and this is why I have so much respect for women, because again, there's a very vulnerable period in one's life or a family's life. So I think just be as open as possible with your providers.
Thank you both very much. Scripps offers comprehensive prenatal care, labor and delivery services, and if necessary, specialists in high-risk obstetrics and neonatology are available. If you'd like more information on high-risk pregnancy, just click on the link or go to scripps.org/videos. Want more critical information about your health? We take care of you from head to toe. Please subscribe to our Scripps Health YouTube channel and follow us on social media at Scripps Health. I'm Susan Taylor. Thanks so much for joining us. It's our mission at Scripps to help you heal, enhance, even save your life.